Now the second half comes. This is more climax. Because spasticity, the most challenging one is spasticity. We always feel that the velocity dependent spasticity is a torture. Subject suddenly becomes overactivity of the muscle, and then it takes a long time to actually come out of the spasticity. And you know that for those patients, more than the PNF, neuromanual therapy will be useful. Because this synergy, the spastic synergy position itself, is actually an offloaded position of median nerve. So if you are actually targeting the loading, median nerve loading, it means that it is a spasticity inhibitory position. So neuromanual therapy is more indicated in loading patterns, especially for spasticity, not for the hypotonia, not for the task-related dynamic movement of normality. Okay, it is more of a static hypotonia or reflex-initiated hypotonia, or it can be even voluntary. I want to pick up that object from the table, then immediately a normal upper limb which is like this, a spastic upper limb like this. When you tell me to touch, it becomes volitional. Okay, so when I have to do an activity, that time the spasticity comes in the picture. So all this are different types of spasticity. A patient who is coming to you like this is different from patient who has like this. You ask him to reach forward, and reaching forward time it becomes like this. So there is dynamic spasticity, functional spasticity, and static spasticity, and contractures. In other terms, the Tardieu scale is there, which gives this actually as the rating. For the voluntary control, we have the Brunstorm also. That also tells about the stages of motor recovery. That also can guide for task control and task training. But what is important here is this neuromanual therapy, when you are doing it, is very, very challenging because you are going against the spasticity. So then how you can do? By activating the antagonist, by influencing proximal to distal. So there, to make the neuromanual therapy better, we are incorporating the PNF. So that means in a flaccid stage, hypotonia, what is our goal? Facilitation. Which technique is better? If you ask me PNF and NMT, which one is better means, obviously PNF is better for the flaccid stage. So when we use the PNF, how we can use it for the nerve? Neuromanual therapy, integrating there in the plasticity. So flaccidity is like 70% PNF and 30% NMT. 100% is functional. Okay. Without functional, there is no treatment. Here, spasticity is NMT is 70 and PNF is 30. We use the PNF to ensure that the NMT don't get restricted. NMT don't get affected. Okay, so that is our goal. And that we can influence with joint compression distractions or antagonist activation, or even by tuning fork, because that is also tuning fork on the tendon of a muscle also is a proprioceptive stimulus. Percussion hammer on the muscle also is a proprioceptive stimulus. So remember that sustained pressure will inhibit the spastic muscle also. A quick pressure will facilitate a flaccid muscle. All these are proprioceptive stimulus. You might think it is Root's approach. That does not matter. Point is which technique and how we can combine and how we can rationale that we can make a technique better. Because NMT may not work in all the spectrum of the cases. When it is flaccid, we need the PNF to work together. PNF is maximum, the boss. It is like two batsmen who are playing cricket in the field, in the pitch. Somebody is batting well, you prefer to stay on the runner side. Just to give the strike to the other player, let him play. Same like that, PNF will be the striker in the flaccid stage, and the NMT will be the runner. Whereas in spasticity, the NMT is the striker and the PNF will be the runner. So that is how we decide. In a stage, in a transition, you might use both nearly equally, or depending upon the task accomplishment, task performance. Because we always think that if the patient is not able to do it correctly, it gives a negative reinforcement and they stop doing the activation or the initiative. So if they do the process correctly also, they are very happy. Accomplishment of the task, picking up the glass, if they're able to pick up, definitely it's important for the caregivers. But for a physical therapist, whether the subject is reaching correctly, the sequential or functional activation, whether it is there, acceptable, because that is energy efficient. I can do abnormally like this and then pick up a glass. But how long I can do? I'll do only 2-3 times and I'll get fatigued. So everything is important there, and to have a what is called as a parallel perspective and integrating this is definitely essential. Neurodynamic test when you simply perform versus after weight bearing, asking the subject to push your hand as a proprioceptive stimulus. After that, you do the neurodynamics. It will be easier because proprioceptive stimulus will enhance the neurodynamics. So that is what we expect in a spastic or a hypertonic scenario. And then he highlighted about partial body weight support system, aquatic, because these two, the body weight, equilibrium, balance and proprioception, all will go parallelly. Line of gravity shift, either from the trunk or from upper limb. So body weight is a major factor. To control the trunk, then control comes from the lower limb or for the upper limb. Trunk control, then it comes. And gravity is a very, very important challenging force. For a normal person, gravity is a friend. But for a stroke patient, the gravity becomes conflicting. It worsens the scenario. That is the reason when the subject is sitting versus subject is supine lying, subject is sitting versus standing, the performance is different because the influence of the gravity becoming higher in standing. Supine to sitting also, gravity becomes higher, base of support becomes lesser. So all this, we need to think in terms of our functional analysis. A patient who is able to do the shoulder lifting in supine, but in sitting the shoulder is not lifting. You know that, yes, biomechanically it is core muscle weakness, but it is the influence of gravity. So when partial body weight support system is given, the focus goes more into the proprioception rather than the body weight. So kinesthesia will get more preference than the joint compression in the knee or in the hip or ankle. That reciprocal action of lower limb training, for example. So there that kinesthesia, movement sensation, flexion of my hip, flexion of the knee, that focus can easily go to the patient because gravity is supported. Body weight is supported. Same like that effect can happen in aquatic therapy. So these all things are as per the infrastructure that is available in the clinic. But the most important resource which you have to actually nourish is the intellectual infrastructure. So that, and then the discussions, interactions, because each person, each clinician will have one experience. When we interact, we explore the mechanism by which that patient improved. There will be a parallel perspective to everything. That is why our interactive webinars are there. And we facilitate interaction. Without interaction, there is no learning. So understand these two components, one for the PNF and the other for the NMT. And the NMT is not just nerve stretching, it is nerve massage also is there. Nerve sliding is most important. Nerve tensioner will happen in the end range only. But nerve sliding will happen everywhere except the end range. And sliding itself will enable a better transmission of impulses both ways, from a hypertonic muscle to up or from cortex to the hypotonic muscle. Both ways it will help. Hypotonic muscle afferent is less. Efferent is important, okay, to activate that hypotonic muscle. Hypertonic muscle, efferent is out of control. Afferent only we can modify. So that is how we actually target the different directions. So the sliding of the nerve will not be the same for a flaccid or a hypotonic muscle to a spastic or a hypertonic muscle. It's the same muscle even then. And the task of reaching out is different from task of picking up a glass. Because picking up a glass, we use flexion. For that flexion, whether you need musculocutaneous nerve for biceps or you need inhibition of the triceps radial nerve. That is clinical decision making, for which only we have courses to identify which nerve to target first. So see that in our the neuro rehab that also demonstration also we were highlighting this. But more in-depth learning happens whenever you are having a relationship with reality. So you have apply something in reality, discuss, learn, then we learn better and better. And then after 6 months, you will see that more better neuro rehab approach will come. That is the duty towards knowledge that we have as physical therapists, right?